Hey, hello everyone. I'm Jody West, and it is 12 o'clock, so we're going to go ahead and get started. Um, Go ahead and mute my phone. I didn't listen to the adequate slides we just had, but we're going to go ahead and get started. Thank you for joining us today. My name is Jody West, and I am the coordinator for the Pediatric Tele-Echo. This is our agenda today. We're going to do our best to stick to this schedule after do a few announcements. Dr. Olivier is going to lead us through introductions. And then Dr. Queen will present our didactic today. And then we'll move into our case presentation that Sienna is going to present. So we're going to do our best to stick to this. We'll have some time for questions and answers, but just before we get to introductions of everyone else, my name is Jody and I am the coordinator. I am also the program manager for the provider to provider consultation line. We are a no-cost mental health teleconsultation program across the state of Louisiana. We focus on mental health needs pediatric patients, which is 0 to 21, as well as perinatal, pregnant, and postpartum persons. We have mental health consultants that have specialty training, and we also have psychiatrists that we can link to providers to if there's questions. So the echo and training is part of the services, as well as the consultation that the provider to provider consultation line provides. If you scan this QR code, you can get more information about our program. You can also send us an email at any time. We are a provider-facing program, so we don't take over the care of patients, but we do work with providers to build the capacity for starting intervention for mental health needs in primary care and other settings, while there may be a wait to get to other resources. So that's me, and that's the provider consultation line. I'm going to throw it to Dr. Olivier, who's going to lead us in other introductions.
All right, good morning, everybody, and or good afternoon, actually, and welcome back to session 2 of our Pediatric Behavioral Health Echo. It's great to see some returning faces from the last Echo session and some new ones. So thank y'all for taking the time out of your lunch break to be here. I'm Dr. Olivier. I'm a child and adolescent psychiatrist over in private practice in Lafayette, Louisiana at Bloom Mental Wellness. I'm also the facilitator for this meeting, so I will help make sure that things are running on time. I will ask the rest of the hub team to introduce themselves, starting with Dr. Queen.
All right, I'm Dr. Katie Queen. I'm a general pediatrician, and I also practice obesity medicine, and I have been part of this hub echo team. This is my second, I guess, year as part of the cohort, and I'm really grateful to be here.
Thank you, Dr. Queen. And as Jody mentioned, Dr. Queen is going to be presenting our didactic session today. How about Ashley Hutchins?
Hi, my name is Ashley Hutchins. I'm a psychiatric nurse practitioner here at Bloom Mental Wellness in Lafayette, Louisiana.
Thanks, Ashley. And how about Lena Reget?
Hi, everybody. My name's Lena, social worker and mental health consultant for the provider to provider consultation line.
Thank you. And y'all already met Jody, who is our program coordinator. And so for the next 20 minutes, Dr. Queen is going to present our didactic on treating aggression in children. So go ahead and take it away, Dr. Queen.
All right, we're going to jump right in. If you can forward the slide. So we're going to talk about aggressive and irritable behavior in children. And what you're going to learn today, hopefully, is that you're going to learn how to develop a differential diagnosis when a youth walks in the door with the complaint of aggressive or irritable behavior. You're going to learn how to assess them, how to potentially diagnose them, how to develop a treatment plan, and more importantly, probably most importantly, where do you look to for resources and tools to help the family? What was that? Okay, so this topic is of interest to me because I work in Bogalusa at a rural pediatric clinic. And over the past year, I've had a lot of sort of preschool age children come in with this complaint. And a lot of them are on the verge of maybe getting kicked out of their preschool. The family is just unsure what to do. Some of them come to you saying, can you just give them medicine? What can you do with these kids? they're too young to diagnose them with maybe ADHD. And I've just felt very lost with this topic. And so I took a 3-day course by something called the Reach Institute last October, I think it was. And basically this was one of the major topics, is how do you deal with aggression and how do you, in a very systematic way, address it. So where a lot of this evidence comes from is from something called the 2012 TMA guidelines. So these are 2 published articles or manuscripts, and Reach Institute, which is who taught me, they have had a big part in these guidelines, and it is probably time for them to update them, but this is what we have. So I went with this, and I also did a good review of up to date and included that in the slides. So next slide. So it's important when we talk about aggression or maladaptive aggression, as they write in the manuscript, we're talking about sort of 2 different things, either impulsive aggression. So this is like when a kid just does something they weren't planning on getting aggressive, but it's unplanned. They're not trying to gain something. It's not something that they really had even thought about. It's just an impulse. So think impulsive. And a lot of the times this is just a symptom of another underlying psychiatric disorder. And that is what the TMA guidelines is really trying to tease out. You can click forward. And then there's predatory aggression. And this is when a child, let's say maybe some of those school shooters, have a planned, profitable, and self-controlled kind of deliberate aggression. And the treatment for those kids, this is what they say in the guidelines, is that it's mostly behavioral. And that's not really what we're talking about today. So I just wanted to delineate that. Next slide. So let's really frame ourselves around a patient, a real life patient. So this is a 14-year-old boy who comes into your office, and he's really there. The chief complaint says he has pain and swelling of his thumb after a fight at school. And he reports, and you say well, what happened? What's going on? He's like, I don't know. I just snapped and I just punched the other boy because he just wouldn't leave me alone. He was bullying me basically and driving me crazy. So think about this kid in your office. And obviously, if you're a primary care doctor or provider, you want to probably get an x-ray of the thumb, but then in the back of your mind, you're thinking, what can I do to help this kid who's having some aggression issues? Next slide. So according to the TMA guidelines, they came out with all of these recommendations, and all based on different levels of evidence. And so this first recommendation is probably one of the most important. Is the first step is to engage the patient. So you want to talk to the patient, you want to talk to the parent or the guardian, and you probably want to do some group talk and form a therapeutic alliance. So I want you all to kind of think in your head, practicing saying this, and it sounds really cheesy, but they made us do this in the course, but saying something like, I want to partner with you and your child, or I want to partner with you guys on this. And the reason that's important is because it's almost never going to be a simple answer. It's almost never going to be a simple fix. And a lot of times the family comes wanting a solution from you. Maybe they want a medication or they want a diagnosis, but you are most likely not going to be able to give that during the first visit. So it's very important that you say, I want to partner with you and I want to help work through this. And so that they'll come back, and that this is more a series of visits rather than just one visit with one solution. Next slide. So they also recommend to conduct a thorough initial evaluation and diagnostic workup before initiating pharmacological treatment. And I think that's hard. I think, as for myself, I want to give a quick fix. I want to be like, well, here's the medication script. But the truth is, in psychiatry, and I'm learning this, Dr. Olivier probably can speak to this, that they say sometimes it takes 2 or 3 visits to really do the full assessment and to come up with a diagnosis. And so we have to get away from this idea that we have to have the answer right at that first visit. Next slide. So what does the assessment look like? So developmental history is probably one of the most important things. You want to go back in time. So this 14-year-old, what did his childhood look like? Did he walk on time? Did he talk on time? Was he in any therapies? Does he have an IEP? All those kind of questions. We know that aggressive behaviors and impulsivity does peak in those preschool years. So I guess it makes sense that I'm seeing a lot of these kids because their self-regulation skills are not really developed. And of course, we want to always be thinking about autism because of their issues with self-regulation. Next slide, next forward. And then you want to really go into what stressors could be happening in this child's life. So is there violence in the home? Are they being exposed to violence? In this particular child, actually the next case I'll talk about, there was some violence in the home. Is there any substance use? That would be important for this 14-year-old. Do they have a history of seeing a psychiatrist or a therapist or any diagnoses? Do they have a history of trauma? You want to think about social determinants because those could lead to stressful life at home, which could spill over. You want to think about bullying and other stressors that could be going on at school. So I think all of this is pretty intuitive for you guys. Next slide. I think the things that are not intuitive, at least for me, was to ask about screen time, but not just screen time, but violent screen time. So we know kids nowadays are playing these video games. Fortnite, I guess, is one of those. And also there's a lot of video games. I'm forgetting the name of the one that my daughter plays all the time, but yeah, a lot of aggressive and very violent video games. We all know this. But I think as a provider, I wasn't asking about that. And so I think that's one thing I want you to take away from today is always asking about what other violent or aggressive type things. Are they watching scary movies? Are they watching violent movies? Are they watching things on YouTube that might be violent? So that's probably one of the most important things to ask about because studies do show that that can make the child more aggressive. And then sleep difficulties is also a huge one. I think I wasn't asking about sleep automatically in these kids until I did this presentation. And I think that is super important because obviously if a kid is tired, they're going to be irritable and they're going to feel more impulsive and aggressive. And then also OSA symptoms, obstructive sleep apnea can make a kid not sleep well and then be tired during the day. So you want to ask about all that. And of course, weapons and parenting style all come into a play. All right, next slide. So number 3, they recommend to assess treatment effects and outcomes with standardized measures. So this I actually love because I always feel like if it's just my history and my HPI, I'm going to miss something. So these are ways that you can truly standardize your assessment and make sure that you have something objective to go by. So we're going to get into some examples. Next slide. So one of my favorites that I learned about in the course was the PSC 17. And this is just a general assessment scale that will kind of point you in the right direction. So a kid that comes in with aggressive behavior, you might want to start with the PSC 17. And it is free. It's freely available online. And there's a parent or there's a youth version. And what this does is it sort of separates out the symptoms of aggression into internalizing, externalizing, and attention sort of symptoms. So let's look at an example. Next slide. So when you do the PSC 17, it's positive if the score is 15 or higher. So 15 or higher. And I know it says 17 because there's 17 questions, but the scoring, it goes much higher. And then if the positive score is 7 or more for inattention, you might want to move forward and do a Vanderbilt. Or you may want to do a scared because sometimes scared is an anxiety screen. Sometimes that can also be positive. If they have a 7 or higher on externalizing questions, you may want to do a Vanderbilt, a MOAS, or an outburst monitoring scale. And if they have a 5 or higher, you may want to do a scared, a PHQ-9 for depression, or the Columbia Depression Scale. And again, y'all are going to have access to these slides, but this is just to help you figure out, okay, where do I go from here? So we're going to do an example. So next slide. So this is a true case, a 4-year-old boy, probably my most difficult aggression case. He was extremely irritable and aggressive. His mom recently had wrecked her car because he actually attacked her while they were driving with a grandmother. Next slide. So I had just taken the course and I was like, I'm going to pull out my PSC 17. So I pulled out my PSC 17, which I had just printed from the course, and I had Mom fill this out. Now, obviously, I did not know how to score it the first time. So ignore my scores at the bottom because I didn't know what I was doing. But when I went back for this presentation and I did the scores, I saw that he scored a 4 for internalizing, a 6 for attention, and an 11 for externalizing. So remember the previous slide, it would have to be 7, 7, or I'm forgetting. Go back to the previous slide. 5, 7, 7, 5. Okay, so move forward. Thank you. So he was positive for externalizing. Okay, so then I went on to the next screen, which was the MOAS. And I also did a Vanderbilt, which I don't have scanned in here. But the MOAS was the Modified Overt Aggression Scale, also freely available. And he did score positive on the MOAS. Okay, on the Vanderbilt, which was interesting, and I didn't realize there was a preschool Vanderbilt. So in retrospect, I should have done a preschool Vanderbilt, but he did score positive on the parent, but not the teacher. So I didn't think he had ADHD. Next slide. So again, I want you to get familiar with some of these screens. And if you're in primary care, that PSC 17 and the MOAS are great to add to your armamentarium. I think everybody knows the Vanderbilts. Everybody, I think, probably knows about the GAD-7 or the SCARED, the PHQ-9, but these are things that I wasn't aware of, and I hope you get out of this talk. And then that link at the bottom has all of these standardized assessments for free. So next slide, we're going to speed it up a little bit for the sake of time. So this is the differential diagnosis of aggression. It's very broad. And remember, it's often something underlying rather than a primary diagnosis of ODD or conduct disorder, which I used to think, oh, I just need to give them that diagnosis, but it's often something underlying that. In this particular 4-year-old, it was actually PTSD. He had witnessed his mom and dad. His dad was physically abusive. His dad's now in jail. And there was a lot of violence in the home. And mom was also, in some ways, not able to parent him in the way she needed to because she had been a victim of abuse herself. Next slide. So what is oppositional defiant disorder? So this is an angry or irritable mood, argumentative, defiant behavior, vindictiveness. So at least 6 months. So just remember 6 months. So this kid, this 4-year-old, he did meet that diagnosis, but it still didn't change the fact that he had underlying PTSD, which ultimately that was the treatment he needed to go to therapy for that trauma. And it has to have impairment in the homeschooler community and often precedes conduct. So this is something I didn't realize, but conduct disorder tends to come later in life. And that tends to be, I guess, it's sort of like the stigma of the people who become the criminals. But as a young child, it's usually something like ODD. Next slide. So true or false? Hope you're paying attention. Your first step is to make a valid DSM diagnosis. The answer is false. Yes, first is assess. Don't feel like you have to. Thank you, Dr. Amy Renner. You don't have to go to the diagnosis. Honestly, if I didn't even diagnose this 4-year-old with ODD, it didn't matter. It wouldn't change my management. What really mattered is that I got deep into the questions and got below the surface and asked a lot of questions. Engaging with them in a partnership and then doing a physical exam, looking for like bruises and signs of abuse, and then potentially doing labs or imaging if needed. So next slide. So number 4, so when acute aggression is the reason for referral, conduct a risk assessment, and if necessary, refer to a psychiatrist or an ER. I think this is pretty intuitive. I just wanted to put it in there to realize that there are times where sometimes you may have to send these kids to the ER, and a child can be potentially PEC'd or put in the hospital if their behavior is so extreme that they are a threat to themselves or others. That's one of the boxes that can be checked by the ER physician. So don't forget, you can call PPCL if you're not sure. Number 5, we're gonna speed through these last ones. You want to make sure when they come back, you keep tracking and reassessing. So every time this child comes back, I'm going to end up doing another MOAS. I ended up treating him for his sleep because he was actually sleeping only like 4 or 5 hours at night, and he was just super active. Even though he didn't have the ADHD diagnosis, I called the PPCL line, and Dr. Waldman recommended that we actually consider a low dose of clonidine for sleep, which we ended up doing. And I haven't heard anything, which no news is good news so far. Next slide. Don't forget to obtain collateral information. So don't forget to try to get a medical release so that you can talk to the school and talk to the teachers, because they're with the kid all the time. And that can be a really important partnership to make sure maybe they make a behavioral health plan. Did you know that an IEP can be made just for behavioral health? But sometimes you as a provider have to request that. Next slide. Number 7 is provide psychoeducation. And I think I wasn't doing enough of this, but we as providers, we can provide the psychoeducation. Now we can't bill for it, we can bill by time, but we can't bill as a therapist, but we can provide psychoeducation. So next slide will show you what I mean by that. So with this particular kid, I went into some stuff about positive parenting, and I love this handout. I have it in my office and as a dot phrase. So it talks about, like, this is really easy for the family to understand, how we want the mom to try to give lots of positive attention for good behavior. We want to give attention for annoying, don't give attention for annoying, but safe behavior. So like if the kid is just like slamming a toy on the desk and mom's annoyed, just ignore, tell the mom to ignore it. Don't say anything. However, if there's an unsafe behavior, like the child is hitting his head against the wall, the mom has to intervene, and then she can intervene very calmly. And I think that demonstrating this in the room, so oftentimes, you know, the kids are slamming the door in the room, like we have these doors that open and close, and the mom wants to say, stop doing that, stop doing that. And I'll just tell the mom, hey, look, let's just ignore him. Let's ignore him. And then when he stops, I turn to him and say, hey, good job. You're being so good. You want a sticker? So you can demonstrate this in the office. Next slide. And here's some really good resources. So we're going to go right into those resources. So Yale has a free course. So if you have a really savvy parent, you can refer them to this and they can do this course. I think I'm going to enroll because I could always improve my parenting. Next slide. And then TECC, or formerly TECC, Tulane School of Medicine, has a lot of handouts. That's where I found this positive pyramid. So you can go to provider resources and they've got a lot of great handouts. Next slide. And then 123 Magic is one of my favorites. I've read most of their books, and also they have free webinars. And if you sign up for their email listserv, you'll learn about the free webinars, and they have YouTube videos, but it's actually a child psychologist. He comes to the AAP conference every year and gives out his books. He's a really awesome guy. Next slide. Okay, and then number 8 is, I think this might be the last one, is to develop a treatment plan. Move forward. So that treatment plan is obviously going to include some behavioral interventions. So for young kids, this is a really important point to take home. I want you to understand younger kids, it's almost always focused on the parent. So PCIT is parent-child interaction therapy for those young kids under 6, and PPP. And then for older than 8, it's more like family therapy, potentially some CBT, cognitive behavioral therapy. Residential treatment, putting these kids all in a hospital together, not evidence-based. Next slide. And I know I'm almost out of time. I have 1 minute, so we're going to speed through this. If you get a patient where you want to really go into the type of therapy, you can go to UpToDate, and there's this nice algorithm. We won't go into the algorithm for sake of time, but that does exist. Next slide. And if you are interested in learning more about PCIT, there's a website, and there is LSU Psychology does offer a virtual PCIT program. That's the closest we have to Bogalusa. And I have not had anybody enroll, but they'll ship the family a little earpiece, and they can do video visits while the psychologist watches the family and intervenes by recommending how the mom should react to the kids' behaviors. So it's really interesting on PCIT. Next slide. So if you want to know, well, who offers PCIT in my area, you can go to this website. So this is the LouisianaEvidenceToPractice.com, and there's a map, and you can put in your zip code. And the closest place that we have is Covington, although they have a huge wait list. So I've been going with the LSU virtual. Next slide. And if you are going to consider medications, always treat the underlying disorder first. So this is kind of obvious, but if you find out they have anxiety or depression, consider an SSRI. If they have an ADHD, consider a stimulant. Interestingly, Strattera or atomoxetine has some small effects on ODD, so that might be a good choice as well, but not clonidine and guanfacine unless they have sleep issues. Next slide. And the one medication that has the most evidence is going to be Risperdal. So we won't go into the prescribing practices of this, but if you do have a kid who you really don't have another diagnosis and you know it's like ODD, that would be the one medication that would be the most evidence-based. Of course, you have to consider baseline labs and monitoring and the side effects and the risk benefit. Next slide. If they fail Risperdal, just like with depression, if they fail an SSRI, you do another SSRI, same thing. If they fail Risperdal, you do a different second generation atypical antipsychotic. And the ones I listed are less side effects. And then if you fail a second antipsychotic, you would consider a mood stabilizer, and lithium has the most evidence for aggression. Next slide. I promise I'm almost done. This is a good up-to-date, walks you through, this algorithm walks you through the medication, but it talks about fail 2 antipsychotics, go to the mood stabilizer. Next slide. And the Presto framework is really just a summary of what we talked about. So don't forget to say, I want to partner with you and your family, and you may take several visits to assess the risk. And you want to do your education with the family. Don't underestimate your importance as a therapist. You want to look for support in the community. So you might want to refer to these outside places we talked about. You want to always track with those standardized assessments, and you want to make goals. So I'll often have the child make one goal. So let's make one goal together, and I'll document it, and then I'll ask about it the next visit, and I give prizes if they work on their goal. Next slide. And don't forget to call PPCL. If you are interested in the Reach Institute course, let me know. They offer scholarships as well. And I think that's it. Yes, references, resources. How'd I do on time?
You did great, Dr. Queen. I'm going to ask that we hold our questions to the end. We will have time at the end because I think our case won't take as long as the time allotted, but this is great information, good stuff. I would like a follow-up PPCL echo, just addressing treatment and prescribing for aggression and agitation in children. All right, let's open this back up for questions. Any questions on treating childhood aggression and agitation? And by the way, you will get a write-up of all these recommendations afterwards. Jody is going to email everybody the recommendations from this session.
So I'll ask a question. So this 4-year-old, and this is kind of for you, Dr. Olivier. So I ended up talking to Dr. Waldman. I ended up doing a low dose of clonidine, but it does seem like he met the criteria for ODD. Would that be enough to start Risperdal on him? Because when I was reading about it, it didn't really have an age limit, like a younger age limit, and he's only 4 years old. So I'm just curious at what makes your decision point to start Risperdal?
I think it's the level of dysfunction. So thinking about what is the function of a 4-year-old in life? At 4 years old, he might not really be going to school. I don't know if he's going to school yet. Is he in pre-K or a daycare?
Yeah, he's in preschool.
Okay, so his function at school is to learn. So is his behavior getting in the way of his learning? Like, is he cutting up so bad at school that he's not learning what he should be at that age? Is his behavior, so at 4 years old, he should be starting to make some friends. At 3 years old, you develop imaginative play. So 4 years old, same thing, imaginative play with his peers. Is his behavior getting in the way of him making friends? So that's a level of dysfunction there. Also, too, bonding with family and keeping that bond with family is a function of a 4-year-old. Is his behavior getting in the way of him bonding with family? Like, will no one in the family watch him because he's so wild and aggressive?
Now that is true. That's true. But is that enough? And what would be your youngest age for Risperdal?
Probably, I think the youngest I've ever prescribed Risperdal was 3 years old. And it has to be pretty
what's
severe.
the FDA approval?
FDA approval. You got me. You got me.
I'll look it up.
I think
approved for aggressiveness and autism. You can get it for aggressiveness and autism on label, but otherwise I found it has to be called bipolar disorder.
Yeah. It is off label for just aggression. And same thing with Abilify. Abilify is another one we use a lot to treat aggression, but and that one's FDA approved down to 6 years old for the irritability associated with autistic disorder. And so I suspect risperidone is kind of the same thing, but we do have a lot of evidence-based data to back up using risperidone. Yeah, I don't know if that answers your question. Is his level of dysfunction severe enough to warrant an antipsychotic?
Well, it also seems to be a safety issue in his case if he caused his mom to wreck a vehicle from physically attacking her too. So
That's a
yeah, you know,
huge one.
right. So you've got to just kind of weigh the
Mhm.
risks and benefits there. And yes, it's off label, but if it's ultimately going to keep him safe until he can get more therapy and get, you know, more address more underlying issues, might be warranted.
And would it would be okay to do clonidine and Risperdal?
I would not do the two together to start. Like if you are deciding on using risperidone, I would replace the clonidine with it, because if you give it at night, and risperidone's a 24-hour medication, it's in his system during the day too. It could do the trick of both, like getting him to sleep better and helping with daytime behavior. So I wouldn't do the two together to start.
Okay.
So I was wondering, it sounds, and maybe I'm misunderstanding, but it sounds as though the child is, so I would think that you would want to send the child and the mother to some kind of therapy before treating the child with Risperdal, because Risperdal is a very strong medication and the child is only 3 or 4, whatever. And you know, I mean, why isn't the child in a car seat at 4? My child was in a car seat at 4. So they couldn't have attacked me if they'd wanted to.
That's a good question. I didn't go into
good
the
point.
details of that, but we do have them seeing our social worker who does collaborative care in Bogalusa. And so he is working with the mom and the child, and we haven't started Risperdal. I was just trying to really find out like when would I consider that if the clonidine and the therapy don't work. I was just trying to think of next steps, but yeah, it's definitely, he's young, so that's why I didn't prescribe it at first.
Are they
Well, Katie, as you know, Katie, we aren't really taught to do that in residency. I mean, maybe they're doing that with some of the new residents. It's been a while for me, but would never have thought of prescribing Risperdal before I went into practice, and people said, "Please help me," and I'm trying. So we had to learn on our feet here, you know, and a lot of times in private practice, how, you know, what's the application for using some of these medicines that I initially would have said that's way outside of my wheelhouse. But yeah, I think we all kind of feel that way about Risperdal. Like, well, wait, you know, that's like gets sticky. But yeah, I appreciate the hold on. Yes, and I have to do that to myself constantly, because now that I do prescribe it, then, you know, sometimes I want to do it too fast to try to help, especially when there's a long family history of big brothers and parents and everybody taking stuff for bipolar disorder or whatever, and they're like, can we do this? It can be really hard to say, wait, and let's try therapy that they don't have any investment in, like that doesn't work, you know, or that's what they think, it doesn't work. And you know, but I do have to sometimes put the brakes on. So thanks for the reminder to like, hold on, where's the PCIT? Where's the social worker? Where's all the therapy that needs to be happening? And a little baby dose of clonidine to try to get some sleep is a great place to start, I think, for your kid at 4.
It is.
Yeah, and I saw in the chat the PCIT. They like the mom. I gave her the number to LSU Psych, but she's not in a place that she's gonna reach out for that. And the easiest thing for her was to come back to the place right next door to us and just see our social worker, who's not PCIT trained, but I think they're developing a rapport, and he can treat the mom as well. So I think that's where we're gonna go for right now. Somebody else was gonna say something.
Also, too, some of these kids are so out of control that you do have to medicate before they can even engage in therapy. I'm thinking, I'm smiling at Ashley Hutchins. She has a kid coming in later today that may be that case, like tore up the office. Like this kid will not be able to do any sort of play therapy, PCIT, until they are a bit calmer. So sometimes not, and this is not often, but sometimes you do have to medicate before the therapy so that they can engage in the therapy. It just depends on the kid and the level of agitation.
And I just want to throw in that, with what Kelly was saying about doing medications that we weren't trained on, we had to learn on the fly since, finishing residency. And not only that, a lot of times we're trying these medications before therapy just because it's taken so long to get and find a therapist, especially for a child of 4 years of age or 5 years of age, which I had a child just 5 years old last week that I had to consult with Dr. Wallman, about. And even in my mind, I was thinking, does this kid even qualify for Risperdal? But we ended up doing some guanfacine at night because he was having sleep trouble and aggression. And because of the insurance, couldn't get clonidine. They wouldn't approve it. So we went to guanfacine instead. So it a lot of times we are starting these medications before therapy just because we don't have a therapist to get them to in a timely fashion.
And PCIT is amazing. It's a wonderful therapy, but it is intense. Like that parent has to commit to at least 12 weeks every single week for an hour every week. You have to go, it's in a two-way room where now they do it online, but you have to wear a headpiece. You have a coach coaching you through these interactions. It's a big investment in time. And it's very helpful and it works, but it takes time. Like the first 5 sessions, you're just building rapport with the kid and the parent. You're not working on the intervention, the disciplinary tactics until like the second half of PCIT. So you have to have an invested parent that has the time to do this and the will to do this. The child parent psychotherapy is an option too, which it sounds like what your social worker may be doing with the parent and the child too. It's not as intense and as huge of a commitment, but that's an option too, child parent psychotherapy as well.
I was going to piggyback off of Derek just to say that it may be, and for the reasons that you're saying too, Dr. Olivier, it may be beneficial if mom has her own trauma history that I think isn't allowing her to parent in the way she maybe would like to parent. That may need to happen even before the dyadic therapy can begin and be meaningful, because of how intensive that is and what it requires. So there may need to be sort of some thought into the timeline of these interventions to make the best use of that time when they are able to get into somebody.
Yeah, that's a really good point. And I actually messaged the social worker and brought that up to his attention that she probably needs the therapy more than the child does, because the child is like an angel with me. He sits on my lap, he like gives me hugs. So I know it's something between him and the mom. But she's doing the best she can, but she's the one that probably needs the most therapy.
And that is the basis of all parenting, parent training and like behavioral therapy. It's working with the parent. And I have so many parents that don't realize that. And they're like, well, they just came to see me. They wouldn't see the kid. And it's like, no, that's parent training. Like they're working with you. They're helping you so that you can fix your child, because they are not going to fix your child because they're not with your child all the time.
And it's crazy because we understand it in utero, right? Healthy mom, healthy baby.
Right. Yeah. But we are wrapping up. Thank y'all for all the questions and recommendations. I'll pass this off to Jody.
Yeah, thank y'all so much. I want to encourage Dr. Queen, if you find that it's not working, call back and reach out for Dr. Waldman again. And I also want to talk to offer to the other participants to sign up to present one of your cases at a future session. And that way you'll get all of the input from the participants and the hub team about recommendations like we just talked about with Sienna's case. And so please sign up for a case presentation if you haven't. We're going to put the link to do CEUs in the chat, and I'll also email it out. You have about 48 hours to do that if you need CMEs or CEUs for your licensure. And our next session is Tuesday, April 9th And the presentation is going to be, Dr. Waldman is presenting about obsessive compulsive disorders in pediatrics. So we truly appreciate everybody's participation and attendance today. Please join us and continue to join us, spread the word, reach out to PPCL at any time in between. Don't wait till April. If there's a question that you have, just contact us and we can help either guide with resources or connect you to our psychiatrist that has some specialty training. So thank you for your attendance. Thanks to Dr. Queen and for Sienna for presenting. And I hope y'all all have a good rest of your afternoon. We'll stay on in case somebody has any other questions, but take care.
Hey, Jody, go ahead and stop the recording.